The title of my talk today is about the new baby coming from Italy from a mother affected by Alström syndrome. I work in a Padua University hospital in Italy, North Italy, and thank you again for the kind invitation to the Alström global meeting, which is very well organized by Alström Syndrome UK. So, going to the topic of my presentation, there are some aspects that have to be considered before going to the pregnancy of this, talking of the pregnancy of this patient. So there are many problems related to Alström syndrome per se that could affect pregnancy. Many aspects are related to the obesity and the endocrine issues that I will present in the next slides. And the other aspects that have to be considered in a pregnancy is the fact that the Alström syndrome patient might be affected by heart disease, liver disease, or kidney disorders. So all these points are very important in the topic of pregnancy. From a metabolic point of view, I have to stress the fact that insulin resistance is a typical feature of a syndrome, and the insulin resistant state might affect the possibility for women to be pregnant also in a wider population not affected by Alström syndrome. But what I mean that the insulin resistant states might induce an increase of androgen levels and polycystic ovary syndrome, and could affect the periods of a woman, so giving irregular menses. So all these aspects might compromise the possibility to be pregnant. And the pathophysiological pathways that connect the hyperinsulinemic state to hyperandrogenism are related to the fact that high insulin levels have specific have a specific action on pituitary gland, on the liver or adipose tissue. And to be simple, I could say that just the high insulin levels might induce an increase of androgen levels, and androgen levels might compromise the possibility to be pregnant, because the ovary doesn't produce the luteal body, so you enter in a state of chronic anovulation. And just to be a little bit complicated, this pathway, we have to stress the fact that the adipose tissue that is represented here is itself an endocrine body, an endocrine organ, and might affect the production as well of some enzymes that affect the production of testosterone, the testosterone, or other hormones that interfere with the normal regular cycle. So when you look at females, this is an old slide of the population that we follow in our university. I just mentioned that when we look at the androgen levels in these patients, we could find an elevation of androgen levels, and this is not dependent only of body weight of the patient, but also from insulin levels. What we know also from the early studies in Alström syndrome is that patients present along the years a fibrosis which affects all the organs of the body, including the testis in male and the ovary in a female. So the testis atrophy and fibrosis in male could compromise the production of the sperm liquid. In the female, and this is an example of an ovary, the fibrotic change in the gland might induce an absence of minimal follicles and no corporal luteal. So this aspect it makes quite give a few possibility for a woman to be pregnant in Alström syndrome. And this model, this aspect has been observed also in mice models. This is a model of double mutation of LH and ALMS1, in which in this model, the ovary of, this is a mice model, the ovary seem to be, looks similar to what we observed in Alström patient with a sort of polycystic ovary syndrome. The single example, the only one example of fertility in Alström syndrome comes from the mice model of Fatu-C. This is the Australian mice model of Alström syndrome, in which have been clearly demonstrated, especially an effect of the mutation in the testis in males. And in this paper, which describes model, the first paper, the authors didn't describe very well. They didn't describe the state of the ovaries. However, they stated in the paper that these mice have been able to reproduce, but only at in the early phase of their life and before the huge increase of the body mass index. So that's what we know from the literature, and this is the background of literature and from the mice model. We describe now I describe now my family of two sisters that have been represented here. Two sisters. One of them was we came in contact with this patient, this family, in 2015, and this patient were referred to our center from the Tübingen University in Germany, and where they have been followed for several years for retinal disorders named achromatopsia. So these two patients seem to be similar to achromatopsia patients, but genetic mutation, and at some point genetic analysis discovered that these patients were not affected by achromatopsia, but from Alström syndrome. Both the sisters have homozygous mutations, but I will show you the next slides. And the father and the mother were had the mutation were heterozygous state. This family live actually in Piemonte region, is in North Italy. Here is Padua University Hospital, and this is Turin, the place where patients live. And this is the region of Italy, the region of origin of this family. And as a curiosity, we know that this family comes from near at 30 kilometers from a small village in which there is a small cluster of patients we have ever been able to come in contact directly. So This is the genetic analysis that, as I said, was firstly done in Germany, but that we replicated in Italy. This is a work done by Gabriella Milan and Francesca Favaretto, which are the biologists of our laboratory. And you clearly see this is the control, this is the father and the mother, and this is one of the sister, this is the other sister. But and this slide is clearly represented the mutation. This is the clearly represented that it is homozygous. You see the mutation in the two sisters. This is the difference from control, in which you see that what's going on. And where is located this mutation? I think this is an interesting point of this story, and of a story of a few other patients that we are following in Italy. And I would be eager to talk with the China scientists, which showed just a couple of minutes ago that they observed some patients with a mutation in this particular point. You see that the two sisters have a mutation in exon 5. So I will stress this point in the next slides, but I want to focus the fact that they both have a full mutation, homozygous in exon 5. And as shown in China, but also all over the world, we have some hotspot point of mutation that are especially related to exon 8, exon 10, exon 16, or other part of a very large gene of Alström syndrome. And few of them are located in this area. So I'm going to describe this patient because this is what we considered in Italy, and we considered in this paper, which is available in literature, which has been carried out especially from the work of Francesca Dacie and Dina Lorusso, which is the psychologist that followed many of our patients in the clinic in Padua University. And what we have been able to see, not only the fact that apraxia could be part of the syndrome, is that some of our patients presented with a mild phenotype of the syndrome. So this 22-year-old female, when we describe this patient, you see that she presented with some of the classical clinical feature of a syndrome, like nystagmus in infancy, and however, the visual impairment of this patient was clearly a Conrod dystrophy, but was of late onset, so not very early onset. And this patient have any history at all of hyperphagia or overweight in childhood, and also at the time of our observation, the clinical, when we come in contact with this patient, doesn't have any problem related to body weight or food intake. And we were surprised by the fact that this patient have any alteration of her metabolic profile. I mean glucose, HbA1c, or insulin levels. And also she presented with regular menses, normal breasts, normal long hair, normal body shape, and she had any liver or kidney impairment. And also the auditory tests were normal. So when you use the Tanner scale tables to classify the development of the breasts or the pubic hair of the general population, we apply this table, and we could say that Tanner stage 3, also in an adult age, is a common finding in Alström patients. On the contrary, the two sisters, and including the pregnant patient, showed a tunnel stage of a full maturation, tunnel stage 5. And however, although this patient was not doesn't have an alteration of body weight, she presented during the clinical history, because we follow this patient since 2015 to a few months ago. You see that along the history of this patient, sometimes she presented with elevation. I don't go deep inside these terms because are quite difficult to follow. Anyway, sometimes she had elevation of androgen levels. You can see here, when we saw the patient almost 5 years ago, this is the glucose tolerance test of a pregnant patient when she was 21 and the sister when she was 25. And you see that the shape of the curves of glycemia, C-peptide, and insulin are, we could say, regular for glycemia. Otherwise, they are not so regular for insulin levels under glucose tolerance test. And it's a curiosity, probably a curiosity, the fact that when we saw for the first time these two sisters, the only one sister that would be willing to be pregnant was the older one. So was the patient that had 25-year-old, and that was 25-year-old. And that time she were willing to become pregnant, and she's still willing to be pregnant today. But as you can see, the pregnant woman will be the 21-year-old patient, but at that time, she was not willing to become pregnant. But I want to stress the fact that this patient was a bit younger, 5 years, and the curves of insulin and glycemia works a little bit better for the younger patient. The heart scan of the patient was at a mild alteration in the longitudinal strain and mild wall motion abnormalities. This is the last scan that we did on the heart, and after 2 years ago, before pregnancy. So this is one. There was this mild alteration of the heart function. This is the audiometry tests of the patient, age 25, 27, so this year. And you see that without hearing aids, the patient is still able to comply with audiometry test, although the specialist he counseled the fact that the patient should start in the next future hearing aids. Anyway, she doesn't feel that she needs to wear this hearing aids at this moment. So this function is very well preserved now. So as I said, we saw in this paper 4 different patients that present with a sort of mild phenotype, and these patients had showed mutation were all upstream exon 7. So at the patient, the younger patient, the younger of the 2 sisters, became pregnant, and I want to show you the fact that Torino, which is the place where the patient lives, and Padua have a distance of 231 miles. So it's 3 hours and a half by car. So we suggested to this patient to come in touch with a center that could follow her pregnancy in Torino. And the data that I will show you in the next slides comes from the collaboration with Professor Luca Marozio, who is the the specialist which followed the patient during the pregnancy. So at a certain point, the patient became pregnant the patient became pregnant in the summer, last summer, in around July of 220, and had a parturition in February 22 this year. And I will show you that during the pregnancy, I will show you some lab tests with the cutoff of a normal score. And these are the tests of liver function before the pregnancy. The red line show you the data during the pregnancy, and this point, the black point, the black point marker, show you the data at the last follow-up in September 21. So we can see that the liver tests were in the normal range. We have just an elevation. However, after the pregnancy, you see that AST, ALT were markedly elevated after the pregnancy, and also the GGT, okay, so the liver function. On the contrary, glycemia and HbA1c, as I said, were perfectly controlled during the pregnancy. The patient doesn't need any kind of treatment specific for metabolic issues that you know could be very frequent in a patient which are affected by any kind of metabolic alteration before pregnancy. And this was of great surprise on my side, because let's see anything related to metabolism in this patient. And the patient was also tested with the glucose tolerance test, and you can see clearly that glycemia at 20 weeks of pregnancy in November last year, you see that was normal response, normal curve of glycemia. So we have been very, very happy to see this kind of results. These are the scan that you see, the scan of a baby done by the gynecologists in Torino University, and you see that the growth, I don't see the normal values, but I can assure you that all the diameters, this is the diameters of a head, this is the circumference of the head, this is the femoral length, so the arm of the lower arm, this is the abdominal circumference, were all regular. So this baby grew regularly, grow up regularly, sorry. And this is the true imaging of a baby. You can see here, this is the only one true imaging that I will share with you about this woman and of a child, because she still wants to be to remain anonymous to the audience. I asked to the mother to talk, to say something at this meeting, but she wanted to remain anonymous, and she didn't want to share any picture of her or of her boy. Anyway, she agreed to share this imaging, and this is the baby in January, just 1 month before the parturition, and you clearly see the nose, the shape of the mouth. This is the arm, this is the trunk, this is the head. So we have a clear face profile of this baby. The other ultrasound aspects related to the fetal heart activity, movements of fluid volume or presentation were all regular. The baby had always a cephalic presentation, placental volume in the right position, posterior. As I said previously, biometric fetal growth was regular. we see any problem in the umbilical artery, and there were any kind of malformation in this baby. The course of pregnancy was regular until the 34 week of pregnancy. At that time, she presented just a dipstick proteinuria at 26 week that was not confirmed. Proteinuria means protein in urine, and this could happen also in normal population, not only in Alström syndrome. And you see that at the 34 week, so at going to the term of pregnancy, the patient developed hypertension and peripheral edema and the cholestasis, so a liver problem related to the liver. So the patient was hospitalized at the Turin University Hospital, Sant'Anna, and she was treated with corticosteroid to induce a full maturation of the pulmonary, so to avoid, to prevent the respiratory distress syndrome. And she was treated since the beginning with calcium antagonist, nifedipine, but due to the lack of efficacy of this medication, she stopped nifedipine and was treated with alpha-methyl-dopa and labetalol. And she went on treatment also with specific treatment to improve the cholestasis, to improve the biliary production of the liver. However, this treatment, the treatment for hypertension was not so, does not control the hypertension, and also protein in urine protein levels were high. So the gynecologists took the decision on February 22 this year to make an urgent cesarean section, and through the surgical section born this newborn male, born regularly, where was no any problem. This is the weight of a baby, 121 ohms. I think, I don't know exactly pronouncing your language. So the Apgar score was 9 at the first 9 minutes. So this is a good score. However, the placental pathology showed that the placental was of small size, at the limit detachment, some vascular obstruction, so a single portion with infarction area. So looking at the placenta, all these aspects spoke for the fact that it was good to induce the pregnancy in this woman. So it was at the end of the story, this placenta. So what about, this is my last slide, what's going on after the parturition. The mother is okay. She had no lactation after delivery, so the baby was fed with artificial milk, and the patient remained in hospital for just 6 days. She returned. She had a resumption of normal cycle, so she have regular cycles, and the baby is growing regularly. I saw these babies. Obviously, is beautiful, and the mother, she's still on therapy with mild treatment for hypertension, but probably we could be able to remove completely, to stop completely in the next few months. My very last slide is about people who actually are still working in our clinic, and you see some data from Francesca Dessia, which is a PhD assistant professor now in Padua University Hospital. Here you have Silvia Bettini, which is working with me following patients. She's a PhD doctor and MD, and she will be working for many years now in our hospital, because she achieved just a couple of days ago a permanent position in our clinic. So I'm very happy of having Silvia with us. And here you see the two biologists and, you know, Gabriella Bettini, who did great work in genetic analysis, and Francesca Favaretto, which is not working anymore with us, but her heart is still beating for us, and she's still in contact with our group. And most of the work is done also by the many collaborations that we have in our hospital. I have to mention the chief of my clinic, the director is Professor Roberto Vettor. I show you some data about the mild phenotypes, as this is related to the work of Dina Russo and Edward Callus. Giancarlo Bombonato is a liver specialist, Antonella Cecchetto and Chiara Palermo are the specialists of the heart function now. They work with us as cardiologists. Dr. Bovo is expert of Mills throat disorders, and Luca Marozio. Many, many thanks to Professor Marozio from Torino, which share with me the data of this patient and gave me the possibility to share with you what's happening in this, I think, extraordinary and fantastic case and successful pregnancy. Thank you for your attention, and hoping to, I'm eager to wait for your questions. Thank you.
Thank you very much, Pietro, and that's just a delightful presentation. Thank you. We have got questions coming in. I'm going to kind of throw it open first of all to Kerry. There's some questions that Kerry's put in there that people have been building on throughout your presentation. I'm going to go on to mute so she can ask some questions first of all. Okay.
Hi, Pietro. Thanks for that. That's fabulous to hear. So at the beginning of the presentation, one of the things, the first question that came to mind really was around the mild symptoms and how the diagnosis was reached in the early stage, particularly because the symptoms were so mild, and whether the mutation on exon 5 had been reported before, and then how the symptoms compare. And then I suppose the next question for me is around any fertility studies in male Alström patients that you're aware of.
So yes, I think that the full clinical spectrum. Can you hear me? Yeah. Okay. I think that the full clinical spectrum of the syndrome had to be completely described. This is I have a feeling. My feeling is that we could have I think also in the normal population, in the wider population, patient that probably might present with just one part of the syndrome, not with a full spectrum of all the disorders that we see some in the majority of patients. And this comes from the fact that probably there is a selection bias of the patients. So probably we select the patients through the eye disorder, and through the eye disorder we do the genetic test. But maybe I think that there could be patients that probably could have just very mild eye disorder. This is my feeling. It's not proven at this point. But what I show you that in our clinic we have some patients that for reasons we don't know exactly why seem to present a mild phenotype, and before this patient had pregnancy, we considered these two sisters as patients with a mild phenotype, and that it was extraordinary that one of them was fully fertile and they have the possibility to become pregnant. So what we show in females, your question, if I understand, could happen also in male patients. Yeah, probably yes. Although we see that for reasons that I don't know, the ovary gland in Alström syndrome seem to be better protected than the testis in male. So we tested in the past some patients for liquid sperm count, and we have seen some that there was some maturation of spermatozoa in the liquid, but we had an experience of we don't know if anyone, at least in Italy, we have any patient which fathered at some point of life. But in theory, it would be possible. In theory, yes. Did I answer to your question? Did you?
Yeah, no, that's fine. Thank you.
Okay.
Okay, thank you, Pietro. A couple of other questions coming in.
Yeah.
I think we've answered one from Alina, but one question is, are there any kind of, to your knowledge, any kind of failed pregnancies of AS female patients being reported?
As far, you mean Alström patient? No, as far as I know, no. I have aware of anyone.
Okay. And another question, did this mum get pregnant by IVF, or was it a natural pregnancy?
It was a natural pregnancy. And I didn't say that the partner was not affected by Alström syndrome. It was not, sorry, it was tested, the partner was tested to know if it was, if he shared the mutation of the syndrome of the patient, and it was not, he didn't share the mutation, and he was not, as far as I know, he had any particular disease, as far as I know, as I remember. Okay.
Okay, thank you.
It was a natural pregnancy, yeah.
A natural pregnancy.
Fertility, yeah.
Okay. Thank you. Okay, so we've got one other question coming in. Bear with me because it's kind of being typed at the moment. But Sandra again says, many thanks, Pietro, for all of the work in this, which is, extraordinary. And then there's a kind of personal question that she might want to follow up directly with you. And just a couple of kind of thank yous from attendees to say, fabulous work by you and the team, but clearly fabulous work by the mum who's had her little Bambino. So I think probably congratulations from everybody. And perhaps that she may feel that she can, kind of share with all of us, should she choose to. Okay, so that's the last of the questions that I can see. However, to everybody who's attending, if there are other questions, please put them in the chat box and we'll try to follow them up a little later. I know some of these presentations the slides are fairly complex. So one of the things we're trying to do throughout the day is just take some have a graphic illustrator with us. She was with us last year, and do some illustrations of some of those. And as I see those, I will try to describe those to you too. Okay, so thank you very much, Pietro. Much appreciated. I know it's a Saturday, really kind of appreciated.
Thank you a lot. Thank you for giving me the possibility to be here and share with you today this fantastic work done not by the doctors, but especially by the mothers. So thank you to all the mothers. Thank you. Thank
you. And I see Laura's just sharing one of the illustrations that she's done. I don't know if she can actually enlarge that so I can describe it to you. I don't know if Laura can do that.
And I can't, but you can. You can pin it. You can pin it for everybody.
Okay.
And there's not a lot of illustration in there yet because I've been concentrating on getting the words right.
Okay. So just a brief description of a first part of an illustration that Laura, our graphic illustrator, has been working on. And it has a little picture of a globe in the corner with global conference, with the title of today's conference of Be Inspired, Be You, Be Together. And she puts welcome to the world, new Bambino, and that we've talked about fertility, pregnancy and phenotype issues. And then the case study, she's just put a very brief description from Pietro just talking about some of the classical signs, that it's two sisters and all the other things that you've heard. We will share these graphics with you afterwards. And thank you very much for, thank you very much, Laura, for doing those as we go through the conference.